Cystic fibrosis, or CF, is the most common lethal autosomal recessive disease, amongst which the most common cause of mortality is respiratory failure. CF is caused by mutations to the gene that codes for the cystic fibrosis transmembrane conductance regulator, or CFTR. The CFTR is an ion channel that sits at the surface of epithelial cells, like those found in the lungs. These channels maintain a liquid layer above the cells that provides a barrier between the cells and mucus. This layer allows cilia, hair-like structures at the surface of the cell, to beat and sweep away old mucus. In CF, dysfunctional CFTR causes hyperabsorption of this liquid layer, which causes cilia to collapse. The resulting buildup of mucus causes chronic infection, inflammation, and ultimately deterioration of lung function. The typical CF patient must visit the doctor up to 8 times per year, not including the average of 1 to 3 hospitalizations required annually for IV antibiotic treatment. On a daily basis, patients also require numerous medications. This results in annual healthcare system costs of about $15,000 per patient. Even with all these interventions, the average life expectancy of patients with CF is only 37 years. What can we do to improve this? If we could predict how patients would respond to specific inhaled therapies, we could enable clinicians to make better informed treatment decisions. This could be achieved by developing a physiologically-based, multi-scale mathematical model of cystic fibrosis. Sound scary? Well, let's break it down. Physiologically-based means that we are grounding our models in actual physical systems. Multi-scale means that we want to look at the effects of the disease at different levels, in our case, the cell, tissue, and organ scales, and see how these effects are connected. By mathematical model, we mean that our entire system will be described using equations, so that we can quickly simulate results on a computer. To develop this, we must tune our model to experimental data from the same patients at all 3 scales of interest. This is made possible by the use of human nasal epithelial cells, or HNEs, for cell and tissue level experiments. HNEs contain the same ion channels as cells at the airway surface, but unlike airway cells, can be obtained from a simple, non-invasive nasal brushing. At the organ level, sequential imaging scans of the lungs can be captured after the same patients have inhaled radiolabeled particles. By measuring responses to a given treatment at all 3 scales, we can link how properties at the cell scale contribute to behavior at the tissue scale, which in turn gives rise to the response visible at the organ scale. Ultimately, this could allow clinicians to predict, from a simple nasal brushing, how an inhaled therapy would affect a specific patient, thus ensuring that they are properly treated and not over-medicated. This all culminates in decreased healthcare costs, increased life expectancy, and an improved quality of life for cystic fibrosis patients.